This program is brought to you by Emory University.
Good morning, everyone. Welcome to Friday Morning Fellows Conference. Our speaker this morning, as you can see on the screen, is Dr. Nida Waheed. For those of you that haven't met Nida yet, she is one of our first-year fellows in the clinical track. She attended med school at the University of North Carolina, did a residency at the University of Florida, and she was a chief resident there last year. And she is going to talk to us today, as you can see, about cardio-oncology. Dr. Waheed.
Thank you. I appreciate the introduction. So I'm going to talk about cardio-oncology, like you said, and just a subset of what the subject matter entails, which is specifically chemotherapy-related left ventricular dysfunction. So I have no disclosures. I'll start with a case and then talk about myocarditis related to immunotherapy. Then we can discuss the broader topic of left ventricular dysfunction related to conventional chemotherapy, as well as the recommendations that discuss how to diagnose, treat, and monitor patients with chemotherapy-related cardiac dysfunction. So we'll just delve into the case. So this is a 30-year-old woman with metastatic non-small cell lung cancer who presented with sudden onset shortness of breath. She noted decreased exercise capacity for a few days before she presented. 6 months prior to presenting, she was diagnosed with metastatic pulmonary adenocarcinoma. She had received 2 cycles of cisplatin and venerelbine, which is an alkaloid, followed by 2 cycles of carboplatin, pemetrexed, and pembrolizumab. Pembrolizumab is an immune checkpoint inhibitor and is part of the class of immunotherapy. Now, due to the significant nausea and vomiting that she experienced, she switched to pembrolizumab monotherapy. She had received 6 cycles at the time of her presentation. In terms of vitals and exam, she was afebrile. She was tachycardic, but it was sinus tachycardia to 110. Blood pressure was a little low at 90/70. Respiratory rate was at 25. And in terms of physical exam, it was significant for bilateral crackles, diminished breath sounds over both of her bilateral lung bases. And she also had pitting edema at her ankles and feet. Labs, these are some pertinent labs. Her white count was normal, so was her hemoglobin, and her CRP was negative. But her NT-proBNP and troponin T that you can see here were markedly elevated. In terms of her EKG, it shows what we had kind of mentioned before in terms of her sinus tachycardia with T-wave inversions in lead 1 and AVL. And her transthoracic echo showed dilated left ventricle with an LV-EDD at 5.5 centimeters and severely reduced systolic function due to global hypokinesis. Her LVEF was estimated to be around 20%, and she had large bilateral pleural effusions, which is consistent with what we saw in physical exam. So at this point, there are a few different diagnoses that we're thinking about. One is viral myocarditis. 2 is immune-related myocarditis following ICI therapy, as well as malignant myopericarditis and pulmonary embolism. A CTPE was performed and was negative. So with the absence of a pericardial effusion and her echo confirming LV dilation and severe systolic dysfunction, myocarditis seemed to be the most likely explanation and diagnosis. So as a next step for the workup, a cardiac MRI was performed. So on the video to the left that's currently moving, we see a 4-chamber view of the LV, and you can see that there's dilation and severe LV systolic dysfunction as we saw in the echo. You can see similar findings on the short axis stack on the right. So it's kind of going down towards the apex. The LV diastolic volume index was 125, and the LVEF was estimated to be about 30%. So these are cross sections from the cardiac MRI. The T2 stir image that you can see on the left, the arrow is currently pointing to a pronounced area of edema in the basal inferior septal wall. On the right, there is a corresponding LGE in the same area as well, and in the anterior lateral wall, as you can see here. So the presence of subendocardial to intramural LGE with concomitant myocardial edema in the basal inferior septal LV wall is a pattern that's actually quite different from the characteristic one you see with viral myocarditis. So viral myocarditis, you will typically see on cardiac MRI, a localization in the subepicardial regions of the LV, inferior lateral wall, and less frequently, you'll also see it in the anterior septal segments. So this pattern is different than that. So after acquiring these images, a left heart cath was performed that showed normal coronary arteries, and this was followed by endomyocardial biopsy. So here you can see both histopathological and immunohistochemical staining. So I'll walk you through this. Panel A shows extensive myocyte necrosis with mainly lymphocytic infiltrates. Immunohistology in B showed numerous CD3 positive T cells, which are seen here, and C shows a significant amount of CD20 positive B cells. And then finally, panel D is actually showing programmed death ligand 1 or PDL1 expression. So the diagnosis of ICI or immune checkpoint inhibitor associated myocarditis from the pembrolizumab that she had received was favored due to one, the cardiac MRI patterns that we previously saw, and two, a substantial myocardial infiltration of the CD20 B cells. That is typically not seen to such an extent in cases of viral myocarditis, and this high level of PDL1 expression that we're seeing as well, which is what the ICI targets. So it was already suspected prior to her getting this biopsy that she had ICI-induced myocarditis. So at that time, she had already started Solu-Medrol at 1 gram a day. Now, her hospitalization was complicated by multiple runs of ventricular tachycardia, for which she received amiodarone and lidocaine. And she actually received an ICD prior to discharge. And at discharge, she was continued on a taper of steroids. This is just another slide of normal cardiac normal pathology slides, just so you can compare what this is supposed to look like. So she came back for follow-up, and here are the images of a follow-up cardiac MRI that was performed about 2 months later. Here you can see that she's had good recovery of her LV systolic function. And I'll show you this short axis view. And it was estimated that it had improved to about 48%. So I showed the top two images earlier, and I've included them for comparison. So the edema in the basal inferior septal wall has improved. So you don't see that enhancement as well on at her 2-month follow-up visit. But you do see the same LGE pattern. So you still see this enhancement here as well as here. So this suggests permanent damage, and in this case, it's likely a fibrotic scar in the myocardium. So at follow-up, in regards to her symptoms, she reported significant improvement in her exercise capacity and no recurrence of her peripheral edema. She was continued on immunosuppressive therapy. She was tapered on steroids. So that ends our case, and I wanted to take a step back and talk a little bit more about what is the immunotherapy and immune checkpoint inhibitors. So ICIs are monoclonal antibodies that activate T cells. This is a simplified depiction of the mechanism. So here the tumor cell binds to the PD-1 receptor, essentially turning off the T cell response to the tumor cell. So if you block this signal by using an immune checkpoint inhibitor, the T cell will be able to fight off the cancer in the tumor cell effectively. Unfortunately, the blockade of immune checkpoints can also induce a broad spectrum of what we call immune-related adverse events, which ICI-induced myocarditis is one of them, due to an autoreactivity in the immune cells. And actually, this phenomenon can happen anywhere in the body. in the GI tract, the eye, lungs. So you see a lot of people in the ICU sometimes who are admitted with pneumonitis from ICIs. So this itis phenomenon, or this ability to just have an inflammatory reaction anywhere in the body, is something that it has been studied in immune checkpoint inhibitors. These are a list of immune checkpoint inhibitors. I just wanted to show the names so that we know what the FDA approved ICI therapies are. And you can see that they've been approved relatively recently. And I know we talked about one side effect, but it's important to point out that these have revolutionized the field of oncology. Cancers that previously had a grade diagnosis are now treatable, which has really just shifted the paradigm. It's important to point out that these are highly effective drugs. They've dramatically improved the survival in patients, and they've essentially have numerous indications now. So they have indications among solid tumors as well, and they're being studied for hematological tumors as well. Their use has rapidly expanded, and they are now used as upfront therapy, and or used in the adjuvant setting. So they're being given upfront. And it's estimated that about 30 to 40% of patients with a malignancy will qualify for some type of ICI therapy. So we will definitely be seeing some of these patients in our clinic. This just shows how many, this picture has expanded, but these show some of the cancers that these are typically used for. So one common question is, how often do we actually see ICI-related myocarditis? The reported incidence has been very low, ranging somewhere between 0.04 to 1%. But reporting has increased over time, and we're beginning to understand this phenomenon a little better. The World Health Organization has a database of individual case safety reports, and they noted increased reporting between 2008 and 2018. So in total, in that 10-year span, they had about 120 cases reported, with only 15 being reported over a 3-year span between 2013 and 2016. In 2016, New England Journal of Medicine published a case report on this topic, and then they had a drastic increase in reporting, with 107 cases reported in 2017 to 2018, so over 1 year. And the same pattern of reporting with as we're getting to better understand this, was also seen in the US FDA adverse event reporting system. So the associated mortality is very high. It's somewhere between 25 and 50%. And if you use combination ICI therapy, this is almost doubled. So both the incidence and the mortality. There's also wide variability in the reported time to onset of symptoms. So here, this is a study published in 2018 that described 35 patients who had ICI-related myocarditis. So you can see this on the left. And you can see the clinical onset, the time to clinical onset of symptoms here. The median time of onset for these 35 patients was 34 days. Oops. And in this cohort, 81% of patients presented with myocarditis within 3 months of ICI initiation. But there have been some patients who have quote unquote late presentations, the longest of up to 450 days after receiving an ICI therapy. In the case I presented, the patient developed ICI myocarditis 6 months after starting ICI therapy. So that gives you about 180 days after she had been started on the therapy. Now, I did want to point out this on the right. So you can see that most patients who have this, immune-related event had an abnormal ECG and abnormal troponin. 2/3 of these patients also had an elevated NT-proBNP. However, when it came down to the evaluation of the EF, it was almost a coin toss between those patients having LV dysfunction or not. So I wanted to point this out because in our case, the LVEF being low was helpful in coming up with the differential, but a normal EF does not rule out the possibility of having ICI-related myocarditis. Now, getting to the diagnosis of ICI-associated myocarditis can be difficult. There are some papers that are out there showing that kind of help in terms of the workup. I think usually it does require a cardiac MRI, sometimes endomyocardial biopsy, but as long as you suspect it, usually people will treat for it. And I think that's the key, is initiation of treatment that is early. So this proposed mechanism for treatment, the first step is to immediately discontinue the ICI and immediately initiate a gram of solu-medrol a day. If they're doing okay, but they're not improving, you can add mycophenolate, which is a potent immunosuppressive agent. If they're unstable, you treat these patients the same way you would anyone else with cardiogenic shock, and you will consider mechanical support. You can also consider adding on a second agent. These are like CTLA-4 agonists. This is something like abatacept. There was a New England Journal case report on using this in patients who had severe glucocorticoid refractory myocarditis that was induced by an ICI. You can also use plasmapheresis IVIG. So this is in the unstable patient who has cardiogenic shock in the ICU. But if they are responding to steroids, you'll essentially continue that therapy. You'll transition them to something that's oral, and you'll do a very slow taper. The reason for this is that the ICI can actually stay attached to the receptor for a long period of time. So if you wean them or you taper them too early from the steroids, you can actually have a flare of their myocarditis. So we just discussed the algorithm, but these novel therapies have only been around really for the past decade, and there's a lot that we're still learning about these drugs. I did put a list just so that we at least see some of the names that we should be familiar with, especially in our clinics. But at this point, I did also want to transition to talking about other classes. So we already discussed a little bit about immune checkpoint inhibitors, and now I wanted to try to pivot and transition to talking about conventional chemotherapy. And when I say that, I mean HER2 inhibitors and anthracyclines. And again, just to put this in perspective, this is a timeline of when certain chemotherapy agents came to be in clinical use and when cardiotoxicity was actually recognized as a side effect. You can see for immune checkpoint inhibitors, they were introduced relatively recently, and we're just starting to understand what cardiac side effects can happen. But you can see here we have a lot more data on anthracyclines and HER2 inhibitors. And these are what inform a lot of our cardiology and oncology professional society statement guidelines. And this is the data that we're going to be talking about at this time. So when I say cardiotoxicity, what do I mean? This is called different things in the literature. It's also called cancer therapeutic-related cardiac dysfunction. And the definition I'm talking about is that they have a decrease in their LVEF of greater than or equal to 10% to an absolute EF less than 53%. Now, this definition has evolved over time. This is generally the one that's most accepted just because it's been studied in the literature, and this is what the clinical trials have used. But you can see that an absolute EF less than 53%, that's not really how we read our echoes. We usually pick either 50 or 55%. So in terms of clinical applicability, I think a lot of people use their judgment in when they would start following patients a little more closely. So just to talk about the mechanisms of anthracyclines as well as HER2 inhibitors. So this is probably the most well-known to us with the anthracyclines. The classic model is to the left, which involves essentially the generation of reactive oxygen species. However, our understanding has really expanded, and the main mechanism now is thought to be due through inhibition of topoisomerase 2B. So without a functional topoisomerase 2B, you have double-stranded DNA breaks that accrue, leading to events such as the activation of the p53 tumor suppression protein, mitochondrial dysfunction due to iron deposits, and the generation of reactive oxygen species that result in cardiac cell death. And this leads to cardiotoxicity. Now, with HER2 agonists, specifically trastuzumab, the exact mechanism is unknown. This is a diagram just showing how trastuzumab works. It binds to the receptor, it's internalized via endocytosis. It causes inhibition of microtubule polymerization, resulting essentially in tumor death. Typically, when we talk about trastuzumab-associated LV dysfunction, it's thought to be reversible with the cessation of therapy and the use of cardioprotective agents. But this isn't always the case, and there have been instances of irreversible LV dysfunction after use. So I wanted to go over the guidelines, the most recent guidelines that we have from the American Society of Clinical Oncology. And these were published in 2017. The way that they're set up is very practical, and they answer a lot of clinical questions. So in terms of their 5 recommendations, it kind of guides you through every step. So which cancer patients are at risk for developing cardiac dysfunction? 2, what can you do before you initiate chemotherapy in order to prevent LV dysfunction? Recommendation 3 addresses how can you minimize risk during the therapy? And then 4 and 5 specifically address what the preferred surveillance and monitoring approaches are during and after they receive their therapy. So recommendation 1, who's at risk? So in terms of who's at risk, 1 is which chemotherapy agents are they receiving? So if they're getting a high dose of anthracycline, which you can see the definition beside it, with doxorubicin being greater than or equal to 250 milligrams per meter square, as well as epirubicin greater than or equal to 600 milligrams per meter square. If they is classified as high risk, the oncologist will know this a little bit better in terms of the dosing, and a lot of times they won't even release the chemotherapy agent unless they have a baseline echo. If they receive high-dose radiotherapy, which is more than 30 grays, or if they receive any lower dose of anthracycline plus radiotherapy, they're considered high risk. Now, they also label high risk if patients as high risk if they get a lower dose of anthracycline or trastuzumab and have the following risk factors. So you can see in the first bullet, they label multiple risk factors include cardiovascular risk factors such as smoking, hypertension, diabetes, dyslipidemia, and obesity. They also include anyone over the age of 60. So this is almost our entire clinic, or a large portion of people that will fall into this category. As well as, and then finally, they also say anyone who's had some kind of cardiomyopathy or MI or some kind of valvular disease should also be classified as high risk. So we will be seeing more and more patients come into our clinics as time goes on, and more people qualify for different chemotherapy agents. And then finally, who else is at high risk? Anyone who gets sequential therapy. And this is essentially them having an anthracycline followed by trastuzumab. So anyone with those combinations of either chemotherapy agents or cardiac risk factors will be considered high risk. So then that brings us to our second recommendation. How do you minimize this risk before you start their therapy? So 1, if they have a modifiable risk factor, to treat it appropriately. But there are also 3 primary prevention trials that I wanted to briefly go over. The first one is PRADA. So PRADA trial randomized women being treated with epirubicin and some who are also treated with trastuzumab to receive either candesartan or metoprolol during treatment. This study showed that candesartan attenuated LV dysfunction, but only by 2%, and metoprolol had no effect. So this brings into question how this can be clinically applicable, especially since there's a very small effect. So then Manticore was published also in 2016. It randomized 94 women to receive either bisoprolol, perindopril, or a placebo. And it showed that both the beta blocker and the ACE inhibitor attenuated LV dysfunction, but they didn't prevent LV remodeling, which was actually the primary outcome studied in the trial. And then finally, the SESI trial. This was published in 2018 and was the largest of the primary prevention trials that have been done so far. It was conducted in Brazil, and it randomized patients to either receive carvedilol or a placebo. So among patients who underwent anthracycline-based chemotherapy, carvedilol was actually not effective at preventing a reduction in LVEF. However, in terms of secondary endpoints, it did show that it lowered the frequency of both detectable troponin I values and reduced the frequency of diastolic dysfunction. So when you have a patient who you consider to be high risk, it's worth considering whether they should be on an ARB, an ACE, or an appropriate beta blocker. So here I wanted to mention a small pilot study. That's the first prospective study we have on patients who already have a low EF prior to starting chemotherapy. So this was called a Safe Heart study. It was included 30 patients. And the primary endpoint was the completion of their HER2 therapy without the development of a cardiac event. And they defined cardiac event as anyone who developed heart failure symptoms or an asymptomatic decline in EF of greater than 10%, or an absolute drop in EF less than 35%. So from these 30 patients, 3 patients met the definition of a met the criteria of a cardiac event. So 2 developed symptomatic heart failure, 1 per protocol had an EF decline that was less than 35%. But this was the first study that showed that patients with a low EF can safely receive HER2 therapies if they were also treated with a beta blocker and ACE inhibitor. So you can see that they used ramipril and carvedilol, titrated the dose appropriately, and it ended up showing that you can give chemotherapy to patients who already have a reduced EF. This was generally the practice as well, I think, in a lot of cardio-oncology clinics, but having some data published, I think, has helped cardiologists and oncologists be more comfortable giving patients chemotherapy. Now, we're going to move on to recommendation number 3. What can you do while the patient is receiving cardiotoxic chemotherapy to minimize the risk of LV dysfunction? One is the use of a drug called Dexrazoxane. And there are 2 other strategies the recommendations mention, but I will not be going over. One is a liposomal formulation of doxorubicin, and one is adjusting the frames of if they're receiving mediastinal radiation therapy. These second 2 really fall under the purview of the oncologist and the radiation oncologist. So in the interest of time, I won't go over that, but I will talk a little bit more about Dexrazoxane. So Dexrazoxane is an iron chelator that prevents the formation of the anthracycline iron complexes we talked about earlier and the generation of free radicals. It also binds to topoisomerase 2B, if you remember, it was part of the mechanism of cardiotoxicity from anthracyclines. And it essentially inhibits the anthracycline-induced DNA breakdown. So this study on the right was published in 2006, included a total of 164 women with breast cancer who had already received treatment with anthracyclines. And they were due for another round of anthracycline-based chemotherapy, and they were randomized to receive either Dexrazoxane or not for a maximum of 6 cycles. So as you can see in the figure to the right, compared with those receiving anthracycline alone, patients treated with Dexrazoxane experienced significantly fewer events, so 39% versus 13%, and a lower incidence of heart failure, so 11% versus 1% in those who also received Dexrazoxane. And the tumor response rate was unaffected. This is pertinent because of a few different reasons, and which I'll get to in a second. But this is also a meta-analysis that was done that included more than 2,000 patients who received anthracyclines. They were divided into two groups, one that received dexrazoxane and the other that didn't. And it showed that they had a relative risk reduction of 0.19, which is a very large effect, and reduced the risk of clinical heart failure. But so then the question really becomes, so why not use this drug concomitantly with all anthracycline-based chemo regimens if it works so well? Right now, it's FDA restricted for patients with metastatic breast cancer or those who have received very high doses of anthracyclines. And this was unfortunate because there was some concern when it first came out that it could mitigate the anti-tumor activity of anthracyclines and or increase secondary malignancies. And there was concern that it could do this more in the pediatric population, especially those who were suffering from lymphoma or leukemia. And this controversial data led to the limited use of dexrazoxane in clinical practice. But there have been multiple studies that have been published since that have shown that the rate of the oncological response is actually not affected. The overall survival is not affected, and the progression-free survival was also not affected. So I think this is really the bottom line, that maybe we should be using this agent a little bit more. Now, this probably affects us a lot as cardiologists. How do we monitor this group of patients, the high-risk patients and those who suffer from LV dysfunction from their chemotherapy? How often should we be ordering imaging? What type of imaging should we use? And is there a role for cardiac biomarkers in all of this? So I don't want you to get lost in this table, but the bottom line is really, we don't recommend the use of MUGAs anymore. That's really outdated, and all the professional societies really recommend getting an echo and monitoring patients with a surface echo. It's important to use the same modality. Not switching between. If you don't have an echo available, they say you could use a MUGA or cardiac MRI. But I think in this day and age, it's widely available. Now, in terms of frequency of monitoring, they do always recommend a baseline echo as well as one after treatment for anyone who receives anthracyclines. There are also some cumulative doses that the oncologist will be paying attention to, which also qualifies them for additional surface echoes. In terms of trastuzumab, all of them, and this is based on clinical trial data, recommend one at baseline and every 3 months. So if they're on for the duration of therapy, and sometimes they're on these therapies for a long time, and they should be getting pretty frequent echocardiograms. But then finally, after they complete their follow-up, after they complete their treatment and they come in for follow-up, they also recommend an echo at about 6 months afterwards to about 12 months, which you can see here. Now, if the patient's doing fine, there are actually no recommendations as to what to do next. So, and if it's compromised, they also leave that to the clinician to decide how to follow up from there. So there are some holes that need to be addressed, and more data that needs to be integrated into future guidelines. So this is a proposed algorithm for monitoring and managing patients undergoing some type of cardiotoxic chemotherapy. So they do recommend baseline exam, EKG, echo. They do recommend biomarkers. And anyone with the EF greater than 50%, they give the green light to get the chemotherapy. You monitor them, as we mentioned on the previous slide, and if they do have an absolute drop in EF that's less than 10%, you continue chemotherapy. Now, if it's greater than 10%, you can start cardioprotective therapy, ACE, ARB, beta blocker, and consider temporarily withholding cancer treatment. They don't say how long to hold the treatment for. So I think this is a discussion that you need to have with the oncologist, because it also depends on which chemotherapy regimen they're receiving. And then, so it's really just, so it's a very, it's a multidisciplinary approach that you're using. Now, there is a gray zone between 40 and 50%. And this falls on the oncologist really to consider alternative non-toxic treatments. Now, there is a benefit risk discussion that happens there, because the first line therapy is usually the most effective. And then finally, if there's LVEF of less than 40%, that's when you start considering, should we actually use other lines of treatment? So this is just a general algorithm, and I think it takes a lot of discussion, both from the cardiac perspective, but also take into account which malignancy they have and what their treatment options are. Because I think in clinical practice, they'll put a lot of people on cardioprotective therapy, and you'll actually just follow them serially, and even if they fall in these two categories, and sometimes not withhold their chemotherapy in general. So this is another, so global longitudinal strain. This is something that can be very helpful especially in this population. So GLS is a parameter that expresses basically longitudinal shortening as a percentage. So you can see the formula. So it's the change in length as a proportion to the baseline length. So here you can see that there's shortening. You do some math where it's like 75 less than 100, minus 100, and you get over 100, and you get minus 25. So GLS is expressed as a negative number, typically. So the more negative the number, the better the LV function. And the reason that it can be a good tool, especially in cardio-oncology, is that it can give you an understanding of which patients are suffering from subclinical LV dysfunction. So it's thought to be more sensitive for this population, and in detecting who will eventually suffer from cardiotoxicity with an EF drop. So it can give you a little bit of a hint beforehand of when you should start cardioprotective agents. So you use speckle tracking, and here you can see that there are different softwares that can be used. This is still something that's being actively studied. It's been mostly studied in anthracyclines and HER2 inhibitors, but a paper just came out, the SECURE trial, a few days ago, showing that this can also be helpful in ICI-induced LV dysfunction. So there's a lot more that I think we can do with GLS. There are some issues with GLS. One, you have to have a very nice picture because of the tracking that happens. You do have to have very good images. And there are also different softwares that are out there that measure them differently. So I think there's some standardization that's needed, but this is something that we'll be seeing more of in the future. Now, in regards to cardiac biomarkers, the studies so far have had small sample sizes and mixed results. The largest study by Cardinal et al., they showed that an elevated troponin I was associated with an increased risk of having future cardiac events. But if you read the study, they drew troponins at multiple times after receiving the dose of chemotherapy. So 1 hour after, 12 hours after, 24 hours, 36 hours, 72 hours after receiving chemotherapy, and then many times after, months later. And the drawing of troponins didn't affect whether how the chemotherapy was given. So it's hard to imagine how this type of surveillance would look like in the United States, especially since we give a lot of importance to troponins. So would chemotherapy be unnecessarily halted due to a troponin elevation? I think that's a risk that could happen from this. So overall, I think the whole point of this slide is just to show you that there is active research being done into what the best cardiac biomarker will be. But essentially, I think the bottom line is regarding the cardiac biomarkers, the verdict is still out. Here, I know in our cardio-oncology clinic, they sometimes draw BNPs because they can see a relative change and it can be helpful. But again, there's still just more data that's needed. So that brings us to the last recommendation, which is monitoring after treatment. There's not a lot of guidance on this. One is always to do a good history and physical. If you do suspect cardiac dysfunction, to get an echo and cardiac biomarkers. And then finally, you do want to get that echo somewhere between 6 and 12 months after completing that the chemotherapy regimen. And there's really no guidance after this point. So if it becomes the clinician who decides how long to follow up. Typically, if everything is normal, there is no follow-up. There is an exception for patients who have childhood cancers who receive anthracyclines. And I think there's some surveillance where they recommend it every few years to get an echo. But that's not applicable to the adult population. So just to kind of summarize and bring up some key points, I think to start off with the case, you do need a high index of suspicion when considering ICI-induced myocarditis, biomarkers being more sensitive, and just remembering that your EF does not have to be low to consider this as a diagnosis. And then when you're considering following people with chemotherapy that can be cardiotoxic, monitoring with echo and considering GLS is preferable, and as well as using beta blockers and ARBs or ACEs for patients at higher risk of developing chemotherapy-induced LV dysfunction. And then finally, if you have any questions, we do have a cardio-oncology clinic here, and you can place a referral or ask questions. So if that resource is there, and I just wanted to bring it up as I think we will need to use it more and more. So thank you for your time. I do want to say thank you to these folks as well who were nice enough to talk to me about cardio-oncology and ask questions. And at this point, I'm happy to take any questions that you have.
Thank you, Nida. I have a quick question. In that the case was excellent with all the MRI imaging and the pathology slides. So when you have a patient that you suspect immune checkpoint inhibitor induced myocarditis, you guys did a biopsy, but let's say you have a high index of suspicion and the imaging is consistent with it. Is biopsy something that's recommended before, ceasing therapy and starting on steroids and that sort of thing? Or is it recommended that you just go ahead with steroids and stopping the checkpoint inhibitor therapy without biopsy?
Yeah, so that's actually a great question. So if the index of suspicion is high enough, you should absolutely start steroids. A lot of times the argument is actually not to do a biopsy because these patients are very sick, they're in cardiogenic shock. So really it's like, what's the utility if it's not going to change clinical management? And I think the real value it has is if that chemotherapy agent, if the ICI is really the only thing that could cure the patient's cancer, then you really want to push the endomyocardial biopsy, because if you prove that it's ICI induced, then you'll definitely switch therapy. And now if it's normal, then you can at least consider restarting it in the outpatient setting. It just has such high stakes sometimes to stop the ICI therapy that's the real utility in getting the biopsy.
Sure. Do you know if starting steroids will lessen the sensitivity or the results of the biopsy?
Yeah, no, that's a good question. I don't know. I could definitely get that information back to you, but my impression is that it does not, that inflammatory process is not that quick to go away. So you still need a few days. So if you get that, if you start steroids and then get the biopsy within a day or two, you should still be able to get the results. Now the cardiac MRI helps because then you can see which areas you should target for the biopsy and not get a false negative.
Dr. Smith says he has a comment and a question. Dr. Smith, do you want to ask?
Yeah,
there you go.
Nida, great talk. Dr. Juan Aranda would be very proud. You came highly recommended from Florida. So couple of comments. One is that in the pediatric population that gets anthracyclines, it's been noted that up to 15% of patients may develop signs decades later. So I think when we see somebody who presents with a cardiomyopathy who had a cancer as a child that was treated with adriamycin, that probably the lead diagnosis is that it was a previous anthracycline cardiotoxicity that presented itself with progressive dysfunction later. And often those children have resting sinus tachycardia during their follow-up visits with their pediatricians. The other thing is that anthracycline cardiotoxicity often affects both ventricles, and in the patients that we see with very advanced heart failure, they behave in some ways more like they have a lot of restrictive physiology in addition to the low ejection fraction, and may be less likely to tolerate sort of guideline-directed medical therapy, and also are at higher risk for right ventricular failure, potentially if they require left ventricular assist device. A question related to the checkpoint inhibitors. I recently saw a patient who had developed systolic heart failure and had been on a checkpoint inhibitor, which I think he had completed his therapy about a year prior, but he had a left bundle branch block. And certainly the checkpoint inhibitors can cause conduction system abnormalities. But as far as just moving forward with a biventricular pacing versus looking for any ongoing issue, what's the time course where you would be concerned about, an ongoing inflammatory response versus prior damage, and how would you assess such a patient?
Yeah, so that's tricky. I think we're getting more data on that. One is we have seen, or the literature does support, that you can have LV dysfunction even more than a year out from your ICI therapy. So could it still be from ICIs? I think the answer is probably yes. Now, two, this is where GLS would be really helpful, is if we had GLS from before, or an echo, it would be helpful just for comparison of whether it's actually due to the ICI or not. So say you had the echo done at baseline and it showed the GLS as -20, and then here it's showing that it's -12, which, again, this is GLS is reported negative, so that's worsening systolic function. Then you can say, hey, this is probably from this agent. Now, if it was -15 to begin with and -15 now, then you can safely say that, hey, it's probably not ICIs. So this is where I think monitoring would be really appropriate. But if you don't have that baseline echo, then it's hard to say.
Yeah, I guess my question is more related to therapy. Just like with viral myocarditis, where often the damage is done, and then later when we see the patients, the inflammation may actually be gone. How long potentially can the inflammation last related to a checkpoint inhibitor?
I think I'm not sure if the data is really out there yet. When I was talking to Dr. Mandawat, he was saying that you can see them more than a year out. But I can ask him a little bit more because he has a little bit, he has a lot of clinical experience and can probably speak to that a little bit more. But I didn't see a lot in the literature really pinning that time frame down.
Based on your presentation, you sound like an expert to me. So,
no, definitely not.
Nida, a question from Dr. Maida. She asks, are there any recommendations for cardiopulmonary rehab to help prevent functional decline post-chemo?
Oh, that I think is a great question.
I presume these are people with documented LV dysfunction. So.
Yeah, no, that's a great question. I think there is very little data out there that I've seen showing that, these are relatively new, especially with ICIs, they're relatively new agents. really people weren't even considering this a clinical entity until around 2016. So right now in the guidelines and recommendations, consensus, expert opinions, anything that I've read, I've not seen anything in regards to them studying cardiac rehab, cardiopulmonary rehab. So it would be interesting to have that study and done and to know more about it. But no, I don't think they've really had a lot of follow-up.
And then another question from Marcelo Fernandez. Hey, Nida, great talk. Any differences in race, ethnicity as it pertains to anthracycline-related cardiomyopathy? Are certain groups more likely to develop cardiomyopathy or decrease in ejection fraction, to your knowledge?
Oh, that's a good question. Not to my knowledge. I think that is that's a very good question. I don't know if it's really been, I'm sure it's been studied. It's just not in terms of a big sample size. So nothing that I can definitively say on how different it is. But I will, that's also another one that I would probably, I can get back to you about. I can, shoot Dr. Mandawat an email and see if he has any more information about that. There were, like I mentioned before, a lot of the studies that have been done have been international. So Cardinal et al. Was in Italy, the SESI trial was in Brazil, but nothing specific.
Well, sounds like we may have two nascent trials on our hands here. One about rehab and one about disparities in or different racial differences. Any other questions from the group for Nida?
Robbie, I'd just make a comment about clinical trials in cancer is that there's so many oncology clinical trials going on that enrolling patients in things that look at cardiac issues in some circumstance can be, more difficult at a university setting like Emory compared to a community setting. It's one of the challenges with looking at cardiac trials in cancer.
Nida, very good talk, excellent presentation, and very comprehensive. Thank you very much for doing that. And while you were presenting, I had a question that may be addressed in a clinical trial, especially in the era now. And I don't know, I hope Dr. Smith is still on the call and maybe he can comment on it. I just wonder if these SGLT2 inhibitors may have any role in improving LV systolic function and or prevention in the setting of these known chemotherapeutic induced cardiomyopathy / myocarditis. Now, myocarditis is a different thing, especially like the patient that you presented, but I'm more concerned about cardiomyopathy that lingers around after it. So that's just a comment and a thought that I had, and I wonder if anything will come out of that.
Yeah, no, that's a great comment. I think that's definitely something to be explored. The other thing that I just wanted to loop in is that, there is a recommendation to get that echo 6 months after they complete therapy. And that's really there because it's thought that right after the chemotherapy is the time where you have, more of the inflammation. And if you have LV dysfunction, you're able to target and, add on therapies, cardioprotective agents within a good time frame so that they don't have long-term effects because these patients are really young. Our patients are a little older, but a lot of the breast cancer patients are really young. So if you can add something like the SGLT2, ACE inhibitors, beta blockers, something like that, if the data supports it, that would be the window of time, I think, to do it.
Yeah, Mahmoud, I think another area is a focus on treating traditional risk factors, particularly hypertension, and particularly in patients who have known heart disease. This probably particularly becomes important with the tyrosine kinase inhibitors that can cause hypertension. The problem is that the oncologists give drugs that cause hypotension. And so they're often fearful of a low blood pressure and sort of have this permissive hypertension, but there is quite a bit of interest as to whether we need to be, quite more aggressive in controlling hypertension in patients who are getting drugs that may have an adverse effect on the cardiovascular system.
All right, well, thank you everyone for tuning in today. Thanks again, Nida, for an excellent presentation, and look forward to seeing everybody next week.
The preceding program is copyrighted by Emory University.